Dr. Leclair, I know for sure she's around because she was the first face I saw letting me know I was in the right place this morning when we were signing in. She is a Chancellor Professor Emerita at University of Massachusetts, and she's been a popular speaker in the past among our previous attendees, given her ability to take laboratory numbers and concepts and language and put it into an understandable way. So, Dr. Leclair, I look forward to having you speak on the topic of learning about my labs and MPN patient guide.
You rang.
Did you hear any of that? I said a lot of nice things about you. Your mother would have loved it.
Yeah, it made me nervous, but yes,
Okay.
I did hear them all. You have put me in this interesting position. My friends to the west just want to have lunch. My friends to the east just want to drink and dinner. And you want me to talk about lab testing to the rest who are postprandially nodding in their comfortable chairs.
Well, keep it short and everybody will be happy, especially me.
Okay. Let's see if I can do this. Nope. So let's try that again. Here, share screen. Yes, I want you to observe my screen. And yes, I want this to be a slideshow. Now let's see what happens. Can you see me?
Perfect.
Can you see the slides?
Yes.
Yes.
Okay. Well, what you're not going to see is I have a handy dandy lab timer right now, and I'm putting it on 20 minutes so I don't have to get yelled at that I'm going overtime. I'm also going to say to everybody who knows me for more than 3 seconds, no, I'm not going to finish. So there's plenty of stuff that will be on this PowerPoint when you get to look at it later. And secondly, when I asked the group a few months ago what topics you wanted, what I got was a number of suggestions that kind of narrowed down to the word everything. So when you get to see the PowerPoints from Crowdcast or from the MPN Foundation, you'll see there is a PowerPoint on thyroid function and testing. There is a PowerPoint on lactic dehydrogenase and testing. And then I guess because Ruben didn't like the fact that I liked cold weather and didn't understand his difficulty, there's also one on COVID testing. So here comes early signs of migration. One of the things that I will go over very quickly is that most of you already know this, but I noticed in the chat a number of first-time attendees, so they haven't heard this lecture about laboratory testing. Laboratory testing reflects a single moment in time. It is the time at which that blood was withdrawn, or that swab was taken, or that other specimen was collected. Once that material is out of your body, the only thing that it can do is degrade. It's not going to move with you. So this is one of the things that you have to understand when you look at all numbers. It includes what happened that day or the day before. The physicians will not want you to know this, but if you run up a flight of stairs just before you have your blood drawn for a CBC, your granulocytes are going to be increased because they slough off the walls of the blood vessels, and they will, for a little while, maybe 10 minutes or so, give you a higher white count. So you have to look at all that stuff. Emotional stress. You sat there waiting for your blood to be drawn or to be called to have your blood drawn, and you hear some kids screaming in the other room. It's probably not putting you in a relaxed state. You didn't have a good sleep last night. For some reason, you might think that there's external stress out there in society, and all of that stuff will react and be reflected on blood tests or in blood tests. Good laboratory tests are accurate about 98% of the time. Would we like them to be 100%? Yes. Is that ever going to happen? Probably not. Good laboratory tests have a very small range of reproducibility. That is, if I take your sample and I run it 10 times, I will get close to, but not always the exact result. For those of you who follow your cholesterol, really now, is there a difference between a cholesterol of 198 and 195? The answer is no. If you follow your and I'm trying not to just concentrate on MPN testing here. If you follow yeah, sure. If you follow your platelet count, I'm sorry to tell you that the difference between a 150,000 and a 160,000 is not really important. You're going to have to bounce it up maybe, or drop it down maybe 20,000 in order to be able to get a significant difference, because those are the ranges of precision for those tests. The tighter the range, the more specific the result. But sometimes you have to make a judgment call. Do you want it accurate? Do you want it precise? And do you want it sometime in the next 5 days? I can give you a superbly accurate blood glucose, accurate to the 4th decimal place. It'll only take 3.5 hours. Well, maybe that's not one you would like to have. I can give you a blood test for cholesterol that maybe only takes 5 minutes and can be done easily and availably in maybe your physician's office. And maybe the range is a little looser than what you would get someplace else. But you make those choices based on the types of patients you have if you're the laboratory. You make your choices of interpretation as a physician based on what the whole picture looks like, and not just a single moment in time. For most of us, you accept the ranges and compare the change over time. So if we started with you had a glucose, it's one of the most easy. If you originally had a glucose of 200 and they said, oops, you're a diabetic, you're going to have to do something about this, and you use some of those skills you just heard about, exercise, diet, meditation, stress control, and you started dropping weight and you started exercising, you would see maybe the next 2 weeks, maybe you would go from a 200 to a 190. Not a thriller. But then you would go down to a 170 or a 160, and then a 140. And over time, what you would see is that there was a trend. There was a pathway you seemed to be following. And that path was leading you to the correct goal that you had. These aren't really entirely invented numbers, but I wanted to show you a little bit of math here to give you a sense of volume in your bone marrow and what numbers have to change in order for things to change in an MPN. There's a general sense out there that many zeros equals the number of cells in a liter of bone marrow, which leads to the question, how many liters of bone marrow do I have? Most adults have 2 liters of bone marrow space. So you have what maybe our MC might describe as a lot of cells in that bone marrow. 1 cell, 2 cells, 5 cells are not going to change what that marrow is doing or responding. You're going to have to get up to a bigger number than that. But everything starts with 1 cell going crazy. Just 1. You're not going to get a whole bunch of cells having a meeting on a Monday and saying, all right, 10 million of us are all going to change in exactly the same way at exactly the same time. You're going to have 1 cell that's going to go crazy. And that cell is going to multiply. Now, some cells multiply very quickly. As a matter of fact, some of them are as fast as every 16 minutes. Others, like lymphocytes, I don't think, and central nervous system cells, I don't think they remember how to undergo mitosis. So there is a wide range of cellular activity that goes on, but for the easy math of it, let's say that we know that it takes about 5 years for that one odd cell to get to enough numbers to cause trouble. And to look at this in terms of numbers, cells that fill the marrow, a lot of them. Cells at time of diagnosis, that would be signs and symptoms to the point where you cannot ignore them. You and I and everyone else listening to this know that there's a period of time where, you deny it, right? I had this funny pain in June, and so who really cared? And yeah, it kept coming back and coming back. So was I entirely surprised in September when someone said to me, we need to put in 2 stents in your coronary arteries, because I had, denied it. I knew it could happen. I recognized the symptoms. They weren't that bad. But see how these numbers kind of go down from signs and symptoms. You can be in a clinical remission in that most of your lab tests are fine, but you still have a lot of cells, because it all goes back to that one bad cell. Now, that's assuming that every single bad cell is going to work perfectly. Well, of course they don't. They're abnormal. Some of them are going to die. Some of them are so damaged that they won't be able to do any mitotic division, or they'll get halfway through mitotic division and then they'll forget what the next step is and they'll die, or something else will happen. So these numbers get to be fuzzier and fuzzier as we go along. So we're talking about maybe longer than 5 years, 7 years. 5 years is always a good number. If nothing bad has happened in 5 years, you're feeling pretty good about the whole thing. So now you want to know, okay, I have this disease. How do I know what's happening in there? Well, it's not easy. Dr. Silver this morning said something about a daily bone marrow. Well, you and I know that's not going to happen. And I would bet you there's a fair number of you right now who are saying, not only are you not going to do it daily, you are not going to do it yearly, or actually, you're not going to do it unless there's no other alternative. So we're not going to pick up a lot of small changes. But you and I also know that progression occurs over time. And you can't say, gee, yesterday I felt fine. Today I feel fine. Therefore, there's no progression. Just like you can't say, yesterday was my surgery. Why aren't I feeling better today? You have to look at this over the long haul, over weeks and months of times. So think dimmer switch. Don't think light switch. This is going to happen small. It will be in fits and starts. It won't even be a smooth road. There's going to be a lot of 2 steps forward, 1 step back, a small jump, 3 steps, 2 steps back. So this is not going to be an easy thing for you to just know. Following everything on your Excel spreadsheet will work, but a lot of you don't like putting down all the numbers either, so that's okay. So how do you know if progression is happening? A lot of you ask questions about, my red cells changed. Okay, lots of red cells change. How do red cells change? What is the possibility of them changing? How do I see whether or not it's not just a one-day deal or something real? Start looking at the RDW. I know it's pretty much down near the bottom of the numbers, but the red cell distribution width is its name. It is one of the most sensitive red cell tests we've got. It starts to get wonky weeks before any of the other cell numbers or descriptions change. Why? Your normal bone marrow is supposed to make red cells that have a quality control that is so good, essentially, they come out like a stack of dimes, one after another, after another, after another. The difference in them is so small, like plus or minus half a micron, that in a lot of times you can't even see the difference. But if all of a sudden populations of red cells start coming out that are stressed, they don't have enough iron to make their hemoglobin, they are looking at maybe fibrosis in the marrow and they're getting damaged, they'll come out as a different size. And RDW checks size. So all of a sudden, if you get varied amounts of size changes, the word is anisocytosis, the RDW starts to increase. Start looking at shape change. Red cells are supposed to be boring. They're supposed to be biconcave shape. So a donut that really didn't manage to get its hole totally taken out. And it's supposed to be kind of soft and kind of like meringue when you touch it. Yes, that's me. I talk to them and I think I touch them. But as you go from essential thrombocythemia to myelofibrosis, for example, oops, sorry about the typo. You've got piano wire across the capillaries. So the red cells can't just leave in their normal fashion. They have to slither through these smaller openings, and they can sometimes get caught. We can have a moment of silence here for what has been described and titled the hung red cells. They didn't do this because they were depressed. They didn't do this because they were lonely. You can see in this scanning electron microscope, as these red cells came across this wire of fibrin, they can get hung up. And if they get pulled fast enough, you get pieces of the membrane that can get caught up and get pulled out. And the cell tries to reshape itself so it becomes like smaller on this side and larger on this one. And this one looks like it's going to be more elongated. And so you get shape changes that are pieces of red cells. My personal favorite is the little fishy in the corner, but you can see how as they try and get out of the marrow, like this one got pulled and this one got damaged, but it's trying to reseal itself. You get these little changes of teardrop cells and spherocytes that are low level, 1 or 2%. You put out trillions of red cells a day. All those in favor of giving your bone marrow a little bit of slack, that it pulls out maybe 1/100th of a percentile or less of these cells. What do they mean? These red cells say something's going on, something is causing stress. These cells might not live as long as a real biconcave cell will, because they're just not as strong in their membranes anymore. So what can you do about that? You could actually do liver function studies that will help reflect those red cell changes. You can do haptoglobin. Haptoglobin is a carrier protein that is decreased when you bust up red cells in your bloodstream. So the lower the haptoglobin, the more cell death is happening. You can use the increased bilirubin. Problem with bilirubin is that it's also involved in the detoxification and excretion of a lot of stuff. So while eventually cell death is going to give a rise in bilirubin, it's not really a very sensitive test. Yes, you can follow it, but it's not as noticeable as, say, maybe some of the other tests that you can have. Going to the other PowerPoint that I'm not going to mention, lactic dehydrogenase will be increased, because lactic dehydrogenase is found in red cells. And when you kill off red cells, their lactic dehydrogenase gets into the bloodstream. So you can have that. I want to add in here that if someday some of those studies on the Herceptin a drug that Dr. Silver was talking about earlier today come through, yes, well, we'll be measuring hepcidin. We can do it. Most people don't order it because at the moment, there's very little that you can do with it in a therapeutic sense. So it will be available when there are medications that interfere with hepcidin are available. There's one other that we used to do. Plasma hemoglobins are not really done anymore, which is really too bad because it would give you a little bit more sense of what's the cell death going on in my bloodstream. Red cells are supposed to last 120 days. My guess is if you were in Texas right now and you were outside trying to shovel your snow or trying to get snow to use for water, you're getting a little cold in the process, and that frost nip in your fingers, it's not serious, but it is painful. That frost nip is causing red cells to die from exposure to the cold. Your plasma hemoglobin would go up. Your lactic dehydrogenase would go up. Your haptoglobin would go down, and probably it's so small, your bilirubin wouldn't change. So those are a series of liver function studies that you could probably either follow or at least look at every now and then. For platelets, most of us, I think by now know that megakaryocytes make platelets, and those are platelets that are budding off. And what's cool down below them is that in picture A, that's a scanning electron micrograph of what platelets are supposed to look like. You know, they're kind of squishy. They've got a few strings attached because they're probing the environment, but that's it. If you put them on something that is, why did those go away? There we go. That is, darn, and my timer just went off. That is glass or plastic or something, they'll spread out. And what you see is a middle center and an area here. And this is what happens when they clumped together. Okay. I can be good and stop here if you want me to.
Susan, let's be good today.
Okay.
You will have to fall upon your sword for the rest of us, and I appreciate it. Again, as you pointed out, your slides will be available to everyone, if not your sweet voice. Thank you so much.
Okay.
We have 3 more speakers.